Welcome. Good morning, good afternoon, good evening to each and every one of you, so that we can, as one family, come together and learn. Participants from 31 countries have registered. First up, we have Professor Gerd Offerth. Professor Offerth is the chairman of the Department of Ophthalmology at the Heidelberg University Eye Hospital in Germany, and is the head of the David J. Apple Center for Vision Research, which includes the David J. Apple International Laboratory for Ocular Pathology.
Hello, everybody, wherever you are and however late it is or early it is. I think that's a very interesting session here on all kinds of gadgets and gizmos that we are using in ophthalmology. And I will kick off the whole thing. We're starting from the anterior part of the eye, and I think we kind of wander through the eye and will end at the retina at a certain time. So I'm talking about an artificial DMEC implant. And I think everybody is aware of the fact that there is a shortage in corneas wherever you are. There are some countries like US have a perfect system, but there are a lot of countries where you have a shortage, where you have no access to corneas, where you have to import them. And if you look all over the world, there are around 12 million people waiting actually for corneal tissue from a donor for all kinds of indications. And when I just look in my country, or let's look at on the European perspective, we can say that we have around 8,000 to 9,000 corneal transplants in Germany per year. And 60% of this, almost 70, are lamellar endothelial procedures, DMEC. We kind of skipped the DSEC development a little bit here in Germany. So DMEC is a predominant way to do surgery. And with that, we have also increased the indication profile and do surgery earlier than we used to do when we only had the perforating keratoplasty available. And so even though we have increased the numbers of transplant and the surgeries, we also have increased the numbers of people on the waiting list. And there are 3,000 to 4,000 people still on a waiting list. So if you look at this perspective, we don't really need an artificial cornea. We need an artificial DMEC actually to satisfy most of these patients, as 60, 70% are DMEC cases in our country. So this is a device I'm going to talk about in the next few minutes. It's called EndoArt from an Israeli startup company, Ion. It's just in the process of getting approved. It's not approved yet with CE mark or FDA. So it's an investigational device, to point that out. The working principle is not to pump out water. It's just to prevent the transfer of aqueous humor into the cornea, or at least to minimize it. A little bit, of course, is good in order to for the nutrition of the cornea, but most of the water is supposed to be prevented to come in. It is a 6 millimeter diameter hydrophilic acrylic, kind of looks like a contact lens from the inside of the cornea, so to say. And the current model has 50 microns. The new model will have only 30 microns in thickness. It's made from a hydrophilic material that we use actually in intraocular lens surgery from one of the basic companies, Contact Mark, that produce the copolymers here. And otherwise, it's more or less an approved material. And the development went through a couple of phases, of course, as you can imagine. Proof of concept studies were done in animals, in rabbits, and pigs. And then actually in 2019, the first human cases were done, and there are now studies going on in Europe and also are prepared in the US to really get into the approval process of this device. And I can share with you 2 cases which I did at the beginning of 2019 as a compassionate trial in 2 patients. Let's start with the first patient. So these were patients where we didn't really have much other choices, so kind of desperate cases. A 58-year-old female that had an phaco intraocular lens surgery quite a while ago, unfortunately ending up in an endophthalmitis, then had a pars-plana vitrectomy. After all these procedures, he had a corneal anesthesia decompensation, even also some problems with optic atrophy, so some secondary glaucoma. And DMEC was tried, multiple rebubbling, but it didn't work, and bullous keratopathy. And she was not really into another DMEC. She was not so into perforating keratoplasty. She was more or less complaining about the pain she has from this bullous keratopathy, which really was bothering her a lot. So this is the preoperative status. You see this kind of damaged eye. You see the foggy cornea. You see 730 micron thickness of the cornea. So the implantation, I cannot show the video right now because we run out of time if I do that. I used an IOL injector, and we injected the lens inside the eye, like we do that with a DMEC lamella. And then actually what we can do is we can use a spatula and just lift it up to the place where we want to put it. We can actually handle the device like an implant and not like the delicate human tissue we have. And then we fixate this also with a air gas bubble. You see here the pictures during surgery when we placed the device on the cornea. And here you see how it's outlined on the cornea with the anterior OCT. You see it's centered in the middle. See the 6 millimeter here. And directly on day one, cornea went down to 593 microns from 700 something. You see already a certain improvement in the clearness of the cornea. And over the time, cornea went down to around 500 micron and became more or less crystal clear in this case. Now let's go back to that case later. Let's look at the second case. I did them both in 2 days. A similar case here, but an old person, 80-year-old male with a Fuchs dystrophy, also status after phaco, status after DMEX, multiple rebubbling, transplant decompensation, and he had also a bullous keratopathy, and you can see the preoperative case here. So here again, similar surgery was performed, and we can see already first day that we getting to 487 microns after surgery. Here we had, after a couple of days, decentration of the implant. It's very easy to go in with the spatula, lift the implant up, put it in the middle, and then do the repositioning. After that, now here you see a 6 months post-op of this case done with the anterior. And you see beautifully how it outlines there, how the cornea is thin and the cornea is clear. Both cases here after 12 months, you can see around 500 microns. You still see here in this case number 2 some epitheliopathy because he had some scarring here. And I actually had this patient a couple of days ago in surgery to do a complete scraping of the diseased epithelium and make the cornea clear for him so that he can see better. So when we look at an artificial DMEC layer here, we can see that the proof of concept at our first patient is correct, it works. Corneal thickness goes down to normal. It really prevents the water from going in. No immunological reaction is here expected because we have a hydrophilic acrylic lens here. It's very easy to handle. We can be quite I wouldn't say brutal, but we can really handle this device with a spatula or with some other device, just push it to the inner surface of the cornea without any problems, especially when we do secondary intervention like repositioning. So it's a very steep learning curve. It's almost like an IOL implantation. For this, of course, we would need, if you look at the future human tissue, a waiting list like we have for human tissue. It can be exchanged if there is a problem. The costs are different, much different. You don't need a cornea bank for this. And even ambulatory daycare scenario is possible. I don't know if this could be a permanent solution for a lot of patients or just a temporary solution until we find a good human transplant. It depends a little bit on the indication, I would say, on the age of the patient and a lot of other factors. Or we use it as a preparation to make the cornea thinner before we do the real surgery. There are a lot of things we can think about it. The proof of concept, I think, is done. We're waiting now for the data of our multi-center trials to really see all the ins and outs and get the approval for the device so everybody can use it. Thank you very much for your attention.
Professor Offer, thank you so much. It is much awaited that we finally have such a thing as an artificial DMEC implant. Let the questions keep on coming in, and we will bring them up during the panel discussion after Dr. Guy Kazarian. So next up, we have Dr. Lisa Arbiser, who is adjunct faculty at the University of Utah John Moran Eye Center, who will be giving us novel prosthetic iris devices. Now, I can speak volumes about Dr. Arbicer. She is a recipient of numerous awards, including the American Academy of Ophthalmology Senior Achievement Award, and has taught on numerous platforms, both nationally and internationally.
It's a pleasure. Iris defects occur under multiple situations, from blunt trauma, which causes an atonic iris in general, loss of tissue from penetrating IFIS, and surgical trauma, which I'd love to give a whole lecture on how to avoid that, and how to avoid when there's an issue with prolapse and so on, and how to avoid prolapse, but that's for another day. Tumor excision, of course, and then eye syndromes and uveitis, often of unknown etiology. Congenital anomalies, including albinism, coloboma, and aniridia. And in aniridia, beware the thin, fragile capsule, which can really be a problem, especially with these devices. Symptoms are really significant, and unfortunately, even a small PI sometimes, strangely enough, can cause diplopia, monocular diplopia, especially in the pseudophakic state, visual degradation, depth of focus deficit, and there are certainly cosmetic concerns when these are significant and the pupil is truly distorted. So we have the potential for a painted contact lens. They're rarely well tolerated. These eyes, by and large, have problems. For example, with aniridia, we have abnormal limbal stem cells, and there's often glaucoma associated. Corneal lamellar intrastromal tattooing is rarely practiced. It doesn't really solve the problem per se, though it can definitely help in very small defects like a PI, where we may be able to avoid the light coming through. Iridoplasty using the native iris, if viable, is always, I think, should generally be our first choice, because not only because of price, but also because of just the fact that as long as we have a fairly healthy tissue that won't cheese wire, we can achieve wonderful results for the patient without the concern of implants. And Choice first developed an aniridia device in '64. Morcher then followed in '91, and that was CE certified, their devices in '94. Ophtec has something that's only outside the US, which I won't cover. Human Optics developed in 2002, and now the Custom Flex is the only approved US FDA approved device in 2018. And has just recently been released in China as well. So pupilloplasty, I'll just skip by pretty quickly. I could give a giant lecture with video on these things, but basically a CTC 6L needle. We only need the 10O proline. I think the chances of degradation due to light are very, very low. So when there's really no tension and we're not going through an eyelet that can cheese wire these sutures, we don't have to go to a 9O or other choices, and a 10O will be fine. There's the potential for a purse string suture, which can lead to a very lovely result, but really 3 imbricating sutures can do just about the same cosmetic job, and we're piercing the iris less, and of course the iris is a very inflammatory tissue. So most of my experience really came from Morcher iris reconstruction implants, and there are a selection of them. They are, for a long time, they required approval in the United States by compassionate use. That's for individual patients. And then we collected data as though it were in a trial, but it was discontinued in 2012, and there's a lot of street information about why that might have happened. To my knowledge, it was not because the devices failed, but rather the regulatory issues did not come through. These were very cost effective, inexpensive. They can be partial to block a small area, or the Rasch-Rosenthal ring can be interdigitated to create an entire pupil. Another device that is more recently developed, which is really quite brilliant, this extra focus device from Argentina, Trindade family. It's currently unavailable, I think, anywhere due to market forces. I think it's unfortunate that by and large, I think people without an iris don't have a lot of income. Strangely enough, I don't know how that occurs, but at any rate, the market it hasn't been deemed large enough for this. The great thing about it is that for aberrated corneas, it can really improve the vision. And Amir Agarwal has come up with the concept of just doing a pinhole pupilloplasty. Of course, if we have retinal concerns, that has to be taken down for good viewing, whereas this implant was different from that point of view. So just a quick video. These Morcher devices are readily available. They are made of black plastic PMMA. They're fairly brittle, so one has to be very gentle and delicate in placing them, and it's a good idea to order two if you know, so you have one in case one breaks or drops to the floor, you know, if you're going to be ordering them specially for a patient. And we can place these rather nicely into the bag, just pretty much like like a CTR, except for this larger portion of the device, and then they can be rotated in the bag after placing a lens underneath them. The Rasch Rosenthal ring will kind of come next here, and you'll see that we can, you know, even have space to remove our OVD, and really one must do that from the posterior chamber because it's going to be a very full bag and we don't want pressure problems. With the Rasch Rosenthal, it's just a little bit more bulky and complex. You do need to enlarge your incision a little bit for either one of these devices, and so a stitch is certainly appropriate at the end. And we can just sort of insinuate this into the bag. It's a lot of stuff, and in my experience, which is not great numbers, I know of two that very late had bag lens complex subluxations and needed to be repaired. And whether that's because the bag is so stiff or heavy, or these patients just have bad zonules that over time will be an issue. One of those patients had a minor trauma that precipitated the bag lens subluxation, and I'm unaware of anything published really about the incidence of that with this much device in the bag, and I'd be happy to hear from faculty if you have experience with that. So getting everything in the right place can be challenging. You can use trypan blue to stain the anterior capsule, which can be helpful not only with this, but with any aniridia device, particularly with the human optics that you'll see in a moment. And then you rotate these so that they interdigitate and create a full diaphragm. And in this aniridia patient, this patient did well for many years. The rage of the day, and certainly the cosmetic benefit to patients, is the custom flex iris. And this human optics from Germany is silicone. It can come with and without the polyester mesh, depending on whether we're putting it in the bag or sewing it to an implant or putting it in the sulcus. It has a 3.35 millimeter central pupillary aperture, and its thickness does demand, if it's in the bag, just a slight correction for the implant if we're being that careful about our outcomes, because it will keep the lens a little further posterior. The brilliance of this is that it's truly a work of art for every individual patient, and we take a photo of the unaffected eye, have a hard copy made, make sure the family and the patient are satisfied with this before we have the artist create this and of course an aniridic patient can choose whatever they like, whereas if you have a unilateral defect, then you want to match the fellow eye. And they've got a beautiful replication of the iris rough, and you can see that it blocks out light and does its job well. This is a video courtesy of Mike Snyder, and one might argue, although you can see how abnormal the iris is in this case, this traumatic case, one might argue that you could reposit that iris, that iridodialysis, and then use imbricating sutures. But when the iris is truly diaphanous and abnormal, this may not work well. These implants are folded into a folder and then carefully placed in the bag using trypan does help. We need to trefine them to fit the bag. Most often they don't need to be trephined when placed in the sulcus. When placed in the sulcus, we do need to suture it almost always, unless there's a lot of native iris just to hold it steady. And I have seen a couple of patients with corneal decompensation post-op sulcus implants. Some people have decided not to place them in the sulcus. Very quickly, beware of cosmetic anterior chamber iris implants. They should never, 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 never be used. They create permanent vision loss, iris destruction, intractable glaucoma, and corneal decompensation, and yet still seem to be available. And that makes me just want to mention something on the horizon very quickly, and that is YAG laser photothermolysis, which is in its very early infant stages, where we raise and lower the temperature of the anterior iris pigment 15 times in 30 seconds with a YAG laser that is a proprietary wavelength, and it stimulates cytokine and macrophage response. Interestingly, it does not create significant uveitis. Barely 1+ cell very early on is seen, and it will not cause pigmentary dispersion glaucoma, at least in the studies to date, which there are 6 years of studies in animals first and now people, and over a couple of episodes you can kind of titrate the color of the iris without interfering with vision, so that may be something of interest in the future. So thank you so much for your attention. Pleasure to be part of this.
You are in for a real treat. Next up, we will have the cataract and refractive surgery segment, starting with Dr. Vance Thompson on light adjustable intraocular lenses. You know, he has this amazing fellowship. His name goes out on multiple levels as being sort of a hero in teaching, a hero in terms of research. And so it is just an honor. You know, I've never met him personally, but I have to tell you, it just takes one email, one word to get a sense of who a person is. And I got that with Dr. Thompson, of how kind, of how humble he is. And so Dr. Thompson, thank you so much for being with us.
Thank you. Thank you so much for having me. This is what an amazing group you've gathered, and I know you've been doing this a while, and I want to congratulate you, Ashiana, for just what you're doing for ophthalmology in the world, and I'm honored to be here today. And I'm going to talk about the light adjustable lens, which is kind of a marriage of refractive and cataract surgery. And I've been involved in consulting and research and development for RxSight, the maker of the light adjustable lens, for many years, and did the FDA monitored trial, and have been using it in all 6 of our centers now for approximately 3 years post approval. And it is an impressive way to deliver premium cataract surgery. And it kind of, as far as our typical journey in cataract surgery, we all know how that goes. And how, like I say to my patients, you were going to replace this lens behind your pupil that used to be as thin as a 10-year-old lens that has now become like a marble or a grape. And we're going to put it in the same capsule or grape skin, and we calculate it's going to sit in the middle. And if it sits in the back or the front, combined with the fact that your incision can heal and increase or decrease astigmatism, it's not unusual at 3 weeks post-operatively, because of your healing variables, that we wish we'd have put in a different power. Well, with the light adjustable lens, we don't have to worry about that, because at 3 weeks post-op, we can verify how it's working for you and how the healing variables have gone along. And we can make adjustments based on your healing and your desires. And that's why I consider it the world's most accurate implant, with no close second. The outcomes have been very impressive. We like to liken it to LASIK-like outcomes in cataract surgery. And it's all because we're able to take those variables and account for them at 3 weeks post-operatively and adjust the power. There's about 100 surgeons in the United States using this technology. COVID has limited the international launch, but it will be coming. And there's, an exciting future for this technology internationally. Preoperatively, what's so, exciting about it is it's very comfortable technology in that you do your, typical pre-op exam and you do your typical calculations. I will say though that the more accurate your calculation, the greater the range of post-op adjustability, and maybe we'll talk about some of this in the question answer session. But if you have a whole bunch of residual refractive error, you may consume all the unpolymerized macromer prior to getting to your refractive endpoint. So try to nail your refractive outcomes, get as close as possible, and use this as a fine tuner. We need to make sure they dilate to at least 6.5 millimeters to have this technology. We do our standard cataract surgery, and then we let it heal for about 3 weeks. And as a result, we like doing these eyes closer together. It's fine to do them a week apart, but probably want to wait till 3 weeks after the second eye to start your adjustment. So we'll either do these a day apart or a few days apart or a week apart, but we typically are starting the adjustment at 3 weeks post-operatively in a patient who hasn't had previous corneal surgery. Previous PRK or LASIK, we wait a little bit longer for the refraction to stabilize. Previous RK, I might even be waiting 8 weeks to 2 months to be making sure they stabilize in incisional refractive surgery. As far as how it fits into our practice, we offer it to all our cataract patients. And in the premium side of our practice, which is about 40% of our cataract surgeries, of the premium side, these are usually about half of the cases, and the other half multifocality. And you'll get your story with time about adjustability and how you want to tell it, but it's really important that the staff understand this. It's also very important to set up patient expectations, because if they need to understand the importance of protecting their eyes from ultraviolet light in all waking hours, indoors and outdoors, and that it's going to be a pretty intense, first couple of months with, especially starting at 3 weeks where we're doing, an exam, a refraction, a dilation, and a light treatment. So those things take a couple hours. And when you're doing 3 to 5 light treatments, it's important for patients to understand. But that early commitment to that 2 months of extra time can lead to a lifetime of visual benefit. It's worth the extra effort. The people that shouldn't have it, those that, are on systemic medications that are sensitizing to UV light, and their general doctor or internist feel like they can't be off those medications, which, to tell you the truth, is rare. But patients with a history of ocular herpes simplex, it can reactivate since it is ultraviolet light. And patients who can't maintain steady fixation, that typically would be rare. And those that aren't going to wear the goggles. I haven't found that the glasses are a barrier. You can wear the clear ones indoor and outdoors if you want. The sunglasses, the shaded, are just for your comfort. You get the UV protection with either one of them. And it actually gets patients talking about this out in the public. And we hear from patients that met others who were wearing the goggles. As far as the patient journey, it's a pretty exciting technology. You do want to choreograph it so that every step of the way is, well organized in your practice. And again, that first couple months is more activity than the average implant. But in my premium side of my practice, lots of times with the multifocal, I'm not enhancing until 3 months after surgery. So these patients also like getting done a little faster. You want to do good quality eye care. Make sure the tear film's happy. These need to be excellent refractions. And you can involve the patient in the visual outcomes. It sure is powerful when, preoperatively, when we're trying to figure out what sort of vision they want, we're oftentimes painting word pictures in ophthalmology. It takes a lot of pressure off the patient when we say, you don't have to worry about that so much with this lens. We can show you your options after your cataract's gone. And just like in a contact lens or a PRK or a LASIK consultation where the media is clear, we can use our same experience post-operatively when the cataract's gone and this clear implant's in, and we're trying to figure out where do we want to, put the refractive air. So that planning is real important. We actually approach it from the slightly hyperopic side. You get the benefit of a little induced negative spherical aberration with this technology. So as a result, let's say I want to do some monovision, which works so great with this. You know how well monovision works when you really nail that distance eye. Well, you can nail it with this technology. But let's say my ultimate goal is plano on the right and -1 on the left. I don't go for that immediately in surgery, because if I approach it from the hyperopic end with my light adjustment, then I'm going to get about a 0.5 diopter bump in spherical aberration or extended depth of focus. So if I want to get that benefit, I want to start from the hyperopic side. So if my ultimate goal is plano on the right and -1 on the left, my surgical goal is going to be plus 0.5 on the right and minus 0.5 on the left. My light adjustment goal will be plano on the right and -1 on the left. And that's how I get that little bit of EDOF. And then I get results like this study by Arturo Chayet comparing it to a multifocal, and just how awesome the results of this technology. I'm a big fan of multifocality too, but boy, this fits into a premium practice. And you really need to, have a plan when you integrate it, because it is more expensive technology, and you need to be able to feel comfortable educating your patients on investing in their future vision. And we do co-management with doctors that these patients are traveling a long ways, and we value that data that they're sending us, because lots of times they've taken care of the patient for 20, 30 years, and they have a good opinion. I look forward to the discussion after the rest of these wonderful talks, and thank you again, Ashiana, for having me here.
Dr. Thompson, the questions are rolling in either directly to me or being posted on the group, so we'll definitely have a bunch of questions. Next up, we have the Vivior Monitor Artificial Intelligence device for cataract and refractive surgery planning with Dr. Arthur Cummings. So when registering, one of the questions that was asked, why are you interested in this course? Most of the topics were highlighted in some way, shape, or form, if not all of the, all. But I loved the answer, one word, Arthur. And that was the answer that came through. That artificial intelligence were indeed up there. Dr. Cummings, in both 2019 and 2020, he was ranked as one of the top 100 ophthalmologists and among the 10 emerging leaders in ophthalmology globally. So Dr. Cummings, I hand it over to you.
Thank you so much, Ashwani, and thank you for the wonderful work you do. I'm going to be speaking about the Vivior artificial intelligence device that helps us with planning refractive and cataract surgery cases. These are my financial disclosures. Vivior applies here. I'm on the medical advisory board, as is Dr. Thompson, by the way. So currently, if we assess patients for trying to figure out what targets they want, we do subjective assessments, in-depth interviews, questionnaires. What Vivior does is have you wear this device on your spectacles. They also have a neck band now that can do it with a different device. But what the device does is it does these visual behavior monitor measurements, collecting working distances with 2 interferometers at 15 degrees apart, collects information on ambient lighting, on your head position, and basically calculates a defocus curve. And we did a study a little while ago with 5 sites in 3 European countries, 123 patients. This is what happened in my own practice. In my own practice, sort of 80% of the work I do in the IOL space would be for cataracts, and 92% would have been using monofocal IOLs and some form of blended vision. During the study, I had more patients coming in for refractive lens exchange, but interestingly, here's the change that occurred because people had used the device. I suddenly found that 66% of patients were requesting a presbyopia correcting lens, an AT IOL, because they understood what the issues were that the technology was going to solve. So what patients found was the data is objective and better reflects their requirements than subjective data. They really felt that their personal needs were being considered. They felt that the surgeon had a greater interest in their outcome, and they felt that they're being heard and that they are playing a part in the selection of their lens. And they also felt that objective data was far more accurate than subjective data. From a surgeon perspective, patient satisfaction increased. There's a better workflow. Better decisions were being based on real data. There were quicker decisions, and patients enjoyed a greater understanding of the compromises involved, and they tend to be less demanding because they know what you're treating. This book, I can't go into detail now, but it's a wonderful book worth reading for anyone in medicine. It's called Invisible Women: Exposing Data Bias in a World Designed for Men. It works across medicine, including IOLs. Our IOLs are simply designed for people who all look alike. And we know we don't all look alike, and our arm lengths are different and so forth. So this is a win-win scenario. So the Viveo monitor objectively measures patient behavior. And here are 6 examples over here. If we had 100, there'd be 100 different examples. But then it matches it to the performance properties of a range of IOLs to compare monofocals, bifocals. You can see the added range of the bifocal. And EDOF IOL, you can see it now including range in the intermediate range. And then trifocals that typically give the widest range. Now, the report would look something like this. With a generic monofocal, you'd see that this particular patient would be out of spectacles for 45% of their day, but the unshaded area, they need spectacles. And then it can also show you every published IOL that has a published defocus curve. It can show you mix and match, can show you different monovisions, can show you target offsets. So it also allows you to choose the level of vision you're looking at, 20/20, 20/25, and all published outcomes on 80 IOLs are at 20/25 because that's very functional vision. So I'm going to give you one case study, and that'll be the end of my talk. So this is data collected recently for a patient just a couple of months ago with many days of data. All you need is 36 hours. The first summary report would show you this patient's defocus curve. Looking at it very quickly, this patient's got quite a unique behavior with 33% at distance, 33% intermediate, sort of a third. And then looking at it horizontally, you can see the lighting that the patient was using. This is the part that's magic for me, is the lifestyle match index. So it defaults to a generic monofocal and shows for this particular patient, if you implanted them bilaterally and got a good result for emmetropia, they'd be out of spectacles for 28% of their day. But for a big proportion of the day, they're using spectacles for closer work. It then goes and does a ranking, which looks much like a Google search, and it ranks it top to bottom, is which lens is going to give them the most additional functionality. And in this case, a trifocal is adding 65% of the functionality. And the only part where they're not doing really well is at exactly a meter. The next thing is a Vivity, which is the new EDOF lens from Alcon, but with an offset of one eye at emmetropia and the other eye at minus 0.75. The next one, in fact, is monovision with one eye at 0, one eye at minus 175. But now you're into the field of monovision and not losing some stereopsis potentially. Then monovision at 0, minus 2, now missing data in the intermediate range. The AcrySoft Restore that we use frequently. In the past, you can see why patients weren't all that happy. There's a big part of the field missing at intermediate. Even mix and match, we'd still leave gaps in the center. And if we implant the Vivity now, which is an amazing lens, and we target both eyes for distance, of course, we're going to get fantastic distance and intermediate, but we're going to be missing out on near. So it really gives us an objective way of knowing exactly where we are. And yes, mini monovision. And now I want to show you why traditionally we're so afraid of multifocal 80 IOLs. That's because when we were using the Restore in years gone by at 2.5, what we would do for this particular patient is we'd only be adding 4% functionality, yet introducing the dysphotopsia. And we programmed to accept compromises if there's a reward. If there's no reward, we don't accept them. So this device has certainly helped us to better educate patients, better figure out objectively what the best lens is for them. And what's key is the data is obtained remotely. It's obtained in the patient's place of work. So we increase presbyopic-correcting IOLs. It enhances patient satisfaction, especially when the IOL is well matched to the patient. it strengthens word of mouth referrals, and ultimately it provides patients with a better outcome and helps them live a fuller life. So thank you very much, Ashani.
Dr. Guy Kazarian, I have a lot that I can speak about his qualities in life. He is someone that, will identify you young or old and pull you in and make you fall in love with global refractive surgery. He's the founder of the Refractive Surgery Alliance, a dear friend, a mentor to me, someone that has really pushed refractive surgery globally in many countries, making the statement that refractive error is a congenital issue and we should be able to provide that care to one and all. And I love that, the to one and all. And I look forward to the day, Guy, when we can achieve your dream and we can all sort of stand proud and give glory to you. So I hand it over to you to teach us about telemedicine in refractive surgery.
Congratulations on making it happen. It's really been very effective. And I think that you're really impacting a lot of ophthalmologists' abilities and awareness and bringing us together as a global community, which is what we are. I'd like to thank my co-authors on this talk, which is Roger Zaldivar and Lance Kugler. Dr. Zaldivar is a company that assists ophthalmologists to excel in telemedicine called Icon Vista. And as you'll hear, there's a big jump in skills between using FaceTime to perform a little bit of telemedicine and then using really immersive telemedicine. Here are my disclosures. Everything I do is around my love and passion for refractive surgery. And as Ashiana mentioned, I think that we live at a pivotal time, and we are the agents of change. This is the first time in human history that we can correct a congenital defect of such functional importance on a mass scale. And we are really changing the world. It's the first time in human history that this has happened. So it's a privilege to be involved in this journey with all of you. Gadgets and gizmos have a great impact on our profession, and yet we have to put them in the context of process. And what about the processes? Have they kept up with our gadgets? A major impact of COVID-19 has been on how we do the things we do. Telemedicine has been a big part of that. And telemedicine doesn't change what we do. It simply changes how we do it. And that change is really overdue. In my career, we've seen amazing technology advances. And really, it's exciting to have that ability. But what we really haven't done, or most people haven't done, is change how we see our patients, how our exam flow goes, how we stay efficient. And it's basically been the same for decades. We simply squeezed more and more diagnostics in the same patient flow process that we always had. And we just had that stack on the front end of the visit, and we would just wait for the patients to come through. And then the shift was that the bottleneck in our flow went from the physician, which is where it should be, to the device workup, the imaging, which is not where it should be. That's very inefficient. And it's a fundamental principle in operations that we talk about in Physician CEO, is that bottlenecks should only occur around the most expensive resource. This maximizes efficiency. And you, as the surgeon, as the physician, are the most expensive resource. Telemedicine gives us a chance to fix this asynchrony in the way that we see patients and make it more efficient. Several forces are driving the adoption of telemedicine right now. Increased acceptance of the virtual world in meetings has been huge, as we're doing now. There's been great awareness of the risks of exposure, for the need of protecting ourselves. There needs to be a compelling reason now for us to come together with other people in the same room. Waiting rooms are no longer acceptable. There needs to be, they need to become more efficient as we adjust our processes, become obvious. And refractive surgeons really need to engage now. We don't want to be left behind. In fact, we want to lead this trend. So expanding our reach is also an important benefit of telemedicine. Think about all the parts of the world that we don't currently reach. Even the parts of, as Vance was talking about, with his co-management across the great state of South Dakota, hundreds of miles. And it's very difficult for people to come to him for every visit, but this way he can reach them at the touch of a button. So telemedicine is really expanding our ability to reach more people. And in the new normal, only the best experiences are going to survive. And grab and go, and no credit card, no overcrowding, lots of deliveries. All these things are changing the way that consumers and patients view their expectations of what they want in their experience with us. And so all of these really catalyze the formation of and acceleration of telemedicine and the adoption. And it's not just about us, it's every field in medicine. Everybody is jumping onto telemedicine. And yet we are particularly well suited for it because of what we have in our imaging processes. Now, the Zaldivar Clinic has really led innovation in telemedicine and ophthalmology. They've been doing it for 20 years, and that leadership continues today. And much of this talk and the concepts that I'm presenting to you and that we're trying to proliferate now come from the Zaldivar Clinic. The word telemedicine can mean many things to different people. And what I want to make sure that we all are talking about the same thing today. We're talking about true immersive telemedicine, not teleorientation, like a FaceTime kind of a thing, but truly immersive where we're actually part of the exam, even as high quality or higher quality to what we do in person because of the digital tools that we're using. And our digital exam process, our imaging and our virtual, our processing of our data is ideally suited for telemedicine. Patients are screened prior to the visit. They come in for a digital exam for the virtual, getting all the diagnostics and the slit lamp done, even in a very high quality slit lamp exam, as you're seeing here in the video, that is done and recorded, all uploaded to the cloud. And then the doctor is seeing the patients one after the next on a schedule that works for everybody. Instead of having patients wait in a waiting room, they're at home and they just click into the appointment. The safety and the patient and the technician is protected during the process. The imaging exams can be scheduled around the patient, making it more convenient for them. It also opens more time to fit patients in for the slowest part of the exam, the imaging part, which they can do at evenings, they can do on weekends. Whenever the technicians can be brought in, they can come in for that, and it alleviates all that digital bottleneck completely. It makes it a totally different flow. We call it the private appointment. When they see the doctor, the private appointment is done, and it's very personal and it's very intimate. Many consultations can be scheduled in a row. The doctor just sits there and goes quick, quick, quick from one to the next. The patient and the doctor review the exam together, and the doctor explains the results. The efficiencies are amazing. There's no waiting, there's no moving, everything's organized. And the impact on the patient is really significant. Most centers are reporting higher conversion rates with telemedicine than they had with their in-person exam, even with the same doctor, which is really quite remarkable. So, we should always be asking, how can we create more value? How can we convert more patients into surgeries? As Vance was talking about with the light adjustable lens, his conversations lead to more conversions with Arthur and is talking about Vivia. We're all looking at the same thing. How can we help people to become more aware of the incredible technologies that we have and make this happen? And this is what telemedicine lets us do, because we get this personal visit with them. And we've shown metrics on every single element that's listed here improves with the telemedicine experience. So we're monitoring these, we're studying them, and we're reporting on them. And with the patient reported outcomes on this have been very, very positive as well. And again, the Zaldivar Clinic and other clinics now are studying this, and they have been for years. Think about the patient's experience with this. It saves them time, it saves them travel, it's safer for them. It's everything about it is better, and satisfaction has really gone up. So telemedicine acknowledges a critical fact. You're essential, and you can't get sick. Without you, your clinic basically has to stop, right? You are the one that actually delivers the intervention that causes the change. So you have to be protected as well, and telemedicine does it. It protects you while allowing you to maintain that personal, intimate, and direct contact with patients with a Zoom, face-to-face with our virtual technologies. So refractive surgery's been very fortunate. COVID's been hard on everybody. Refractive surgery has been fortunate. We're actually coming out of COVID better than we entered it. People are coming in to get their eyes fixed because their glasses are steaming up. We've had concerns about touching faces and other things driving adoption of what we're doing. There's more disposable income. People are coming in because they have money to spend, and they're not spending it on restaurants and travel. What we're doing with COVID-19 and what we're doing in the last several months is changing refractive surgery from the category of being a procedure, an elective procedure for rich people, to being one that's a functional procedure for working people. And I don't want to lose that position. We must stay in that category of being a functional procedure for working people. And many forces are driving the adoption of telemedicine, the safety, the convenience, the efficiency, the acceptance of digital interactions in the COVID world, and the acceptance of change, frankly. Change is hard, but change is happening, and we can jump into that change bandwagon and make it happen with us too. And refractive surgery is clearly growing, and telemedicine is making it better. It's here to stay. It won't change what we do, but it will change how we do it. So I urge you to embrace the new gadgets and gizmos and pay special attention to your processes. We've entered a new stage for growth for refractive surgery, and telemedicine is foundational for that growth. Thanks very much for having me here today. It's really a pleasure to be with all of you. I look forward to the discussion.
Dr. Kazarian, you just took it to another level. We were talking about gadgets and gizmos, and then your first sentence was we should start thinking about processes, which I love. Let me take a moment and introduce our faculty, okay? A number of colleagues and friends of mine from KEM Hospital are joining us today. Our esteemed head of department, Dr. Sheila Kirker. We have our cornea and refractive surgeon, Dr. Amrita Ajani, Dr. Vikram Nakate, and Dr. Aniruddha Mahindrakar, who are our vitreoretinal surgeons, Dr. Pooja Gala, pediatric ophthalmologist galore, and Dr. Sid Gospe, who is from the Duke Eye Center, a neuro-ophthalmologist and a co-fellow when I was there at Duke for cornea fellowship. So I am going to first start by handing it over to my colleague, Dr. Amrita Ajani, to start off the discussion.
Thanks, Ashiana. So I'd like to start by saying excellent talks by everyone, and we really, really thoroughly enjoyed them. The first question is for Professor Offer. Is there any particular post-operative regime that is different from the DMEC or the DSEC in terms of topical steroids?
No, not really. We think that we don't need to take the steroids longer than, let's say, 4 weeks or something like this, similar after cataract surgery, maybe 3-4 weeks. At the moment, the regimen for the approval studies are pretty similar to a conventional DMEC, even giving systemic steroids. I don't really think it makes sense, but there's some regulatory things that are involved here. So I would assume that a normal post-op treatment with steroids or a combination of antibiotic and steroids, what we usually give after cataract surgery, could be sufficient here. And that's what I think in the future.
The general diameter that you have for DSEC or DMEC is on an average 8 millimeters, right? So is there some particular reason that we have gone in for 6 millimeters?
Yes, they have done in the last 10 years, as you have seen, a couple of animal studies. And even though the animal models are not 100% equivalent to human, they've seen the larger the implant is, the more the cornea can thin. And if you have like a 9 millimeter implant and your central part will go down to 200 microns instead of 500, you may run into a problem. So the 6 millimeters, maybe it's 5.5 would be the ideal size, but something around there will be will assure you that you have a 500 micron corneal thickness, which is supposed to be a normal value you would like to have.
Also on the chat, there was a question mentioned about the interface haze. So I believe your answer was till now, both the patients, I think on a maximum follow-up of 15 months, am I correct? Has had no interface haze. That's excellent. That's awesome. Thank you.
Yeah, but it's an important question because we're putting something artificial in. We have a hydrophilic material. Exactly. So the question is, do we have some interaction? And the funny thing is, we have hydrophilic lenses when we do DMEC that can calcify. Yeah?
Correct.
And here we have also a hydrophilic material that we're using, a very thin one though. And we don't have really that trauma to the eye that we usually have in some of these cases that have opacified intraocular lenses. So we get a lot at the David Apple Lab. So it's a completely different story here. So I'm not really thinking that we expect that. And even though it is extremely easy to exchange, much easier than an intraocular lens or something like this.
Yeah. And one of the things that, you basically have come like an angel in the midst of COVID, because we are facing global tissue shortage. Okay. And so you're coming at the point where we need tissue, and here you are giving it to us without it being from a donor recipient. Can we talk about the science a little bit? How is it, one of the questions that came up is, are we wrong about the importance of corneal endothelium in maintaining corneal clarity? How is the science behind this implant when we don't have endothelial cells that are here in, the posterior aspect of the cornea?
Well, it's not really so much science in terms of molecular changes or whatever in the cells. The thing is that we have during the night when the eyes are closed, we have water coming into the cornea, and it's actively pumped out by the endothelium. And there have been a lot of observations also by other doctors that it's possible to block that. Yeah, if you, for example, if you have some silicone oil in the anterior chamber, sometimes it also can give you a pretty clear cornea because of the silicone oil, nothing is going in the cornea, no water. But on the long run, of course, it will have a problem to dry it out. Yeah. So they started experimenting with different materials and different applications until they came up with a hydrophilic material that balanced out a certain permeability and still a certain shielding effect. Also, the size is a problem, as you heard, but this could also be figured out. Now what we're looking at is a long-term performance. Is this a permanent implant? Is this a temporary implant? Is this an implant just as an intervention for certain things? So we're still at the beginning. We are here like the 80s with, or 70s with the intraocular lenses, so to say. So that is what we are talking here. But the funny thing is it really works. It's very easy to handle. And I think there is a huge need for these multi-center trials. Unfortunately, COVID is also a kind of problem here, going through these studies and having enough patients to recruit that. So far, around 14 patients have been included in the studies here in Europe, at least. So I think next year we will hear much more about that, and also they will start an US trial, which also I think will be very interesting.
We're looking forward to that, and we're looking forward to it coming into other parts of the world also, Professor Offert. Dr. Arbiser, the big concern that we have, we cringe when we talk about iris implants as it relates to, glaucoma and endothelial damage. How has the technology improved in terms of minimizing the risk?
Well, the human optics is the one that is the most available, or the only available in the United States, and certainly its ability to be placed in the bag is a huge advantage. If we place it in the bag, we're really not seeing any problems per se. Assuming that surgery goes well and so on. With regard to placing in the sulcus, I think there are some people, I think Ike Ahmed may not be placing them in the sulcus anymore. Mike Snyder has the largest experience. He was the lead investigator, and I don't know, has anyone on the panel been an investigator for the human optics iris? Did you, Gerd? So perhaps you would like to answer that question. I did have the opportunity to implant one very early on. It was in an aniritic patient that already had glaucoma and issues, and even though it was sutured in place in the sulcus, he went on to need a limbal cell transplant and so on. So whether how much of a role that played in his general pathology is unknown to me. And if you have more experience, I would love for you to answer that. No matter what, these are sick eyes. If an iris is not normal, the eye is really not normal. The uveal tissue is probably not normal, and there's so much inflammatory associated with that, and so much trauma to get there, or anomaly to get there in the first place. So it's very hard to sort out what it is we're doing to make it better or worse. In my opinion. And of course, these are by and large desperate patients, and there are some wonderful outcomes with the human optics so far.
Yeah, we just published 3 papers actually on the artificial iris in the Journal of Cataract and Refractive Surgery and on PLOS ONE, actually relating to the aesthetic effect, relating to the functional effect, and also relating to the fact that you suture an intraocular lens to the artificial iris, and how the outcome is, how you calculate the IOL calculations. We actually have now also a case where we sutured multifocal lenses onto the iris, quite successful, it's doable. Going back to the glaucoma question, I think Lisa already said, the reason is not the implant. The reason is the pathology behind the reason why they get the implant. And usually it's a traumatic case or whatever that causes a secondary glaucoma, which needs to be well controlled. Actually, also before you plan and talk with the patient, putting that in. And still then you have to tell them that due to the surgery, you have to monitor that very closely. And this can be handled quite well. I mean, these are really sometimes very extensive traumatic cases, which have other issues also like keratoplasty and whatever else. So these are individual patients and a very individualized approach. And the glaucoma thing is one thing, but the outcome is so beautiful. It's unbelievable. Yeah, they look nicer than normal irises, so to say. Yeah. So I really can encourage.
You can even be fooled at the slit lamp initially. I mean, if you look just really quickly at the slit lamp, you wouldn't even know in some cases, particularly in the sulcus.
Somebody had a question on the chat asking regarding how is the residual iris supposed to be managed?
Well, I think that's also part of the art of placing this. Make use of what we can of the native iris, but not have it get in the way. And and so, you know, if we can use a pupilloplasty and an iridoplasty and so on to solve the problem, that's our first go-to. If we're going to place the artificial implant, now we have to use the art of what will look the best. And so, as you can see, there are many ways to alter the edges of the iris with cautery, intraoperative, intraocular cautery, as well as vitrectors, in a very high-speed cutting. And you could see there that that little extra bridge was neither helping nor adding to the cosmetic effect, and therefore was sacrificed in that video.
Does it cause any problems in diagnosis as well as management later on?
Yes, I think they came up with a 3.25 millimeter pupillary opening because in concert with retina people who were part of the consultation, they felt that they were able to access the peripheral retina as needed through that opening. So we would hope not to have to remove it. That would be a big operation and a lot of trauma to remove that. And so to my knowledge, I think that you need to get somebody who really knows how to look at the periphery to look.
So Dr. Thompson, let's talk about adjustability. Can you change the refraction years later? What about examples like a myopic shift after a buckle? If we can also discuss contraindications for light adjustable lenses, are we looking at it in the same way we would, PRK or a LASIK patient?
Well, after you do the final light treatment, and it's basically a mathematical calculation when all the unpolymerized portion of the lens is now finally polymerized. It's not changeable at this point in time. So it would be like any other implant. And whether it's 6 months later, because imagine you've done plano in one eye and -1 in the other over the first couple months, and now they go live with it. And at the end of 6 months, they feel like, kind of wish I had a little bit more myopia, or I'm not liking monovision. What are your choices? Well, then we would do what we've done with every other non-light adjustable implant. We adjust their cornea with PRK or LASIK. So whether it's 6 months or 20 years down the road and they've had a retinal detachment now and they now are more myopic and they miss being spectacle independent and their best corrected vision and everything else checks out fine, to do a refractive corneal enhancement, we always have that option. And that's one of the things I think is very powerful about adjusting the optic, is that you still have that cornea that you can adjust on the long run. And as far as contraindications, someone who can't be off of a UV sensitizing medication would be a contraindication. I've found that talking with their, internal medicine or family doctor, that it would be rare that someone can't be off that medication, which would typically be not before the surgery, it would be a week before the light adjustment. And then after the final light adjustment, they can start that medication immediately. But if they can't be off it, they shouldn't have a light adjustable lens. If they have a history of herpes simplex, they in their cornea, they shouldn't have this done. This is a UV source, and it can, wake up a herpes situation. If their pupil's not big enough, and this is very important, really we're sitting there with a 6 millimeter diameter optic with 5.5 millimeters of it being really the light adjustable portion. So you'd think a 5.5 millimeter pupil would be enough, but remember, as this implant sits in the capsular bag like any implant, it's not unusual that the pupil is decentered nasally or somewhere else. So that's why we feel like you want them to be able to dilate to 6.5 millimeters or greater, so you have a little bit of leeway. So pupil dilation is important. And then after that, it's more physical things. Can they hold still? Can they show up for the treatments, and will they wear the glasses?
What about the chance of dysphotopsia after light adjustable lenses?
Well, there's a couple things to think about. One is if they didn't wear the glasses and they went, and had ambient ultraviolet light irregularly change the implant, then they're going to have issues. So wearing the goggles is important. As far as image quality, it's an amazing lens, and getting a dysphotopsia from this lens, the whole beauty of monovision is you can do the majority of what you do without glasses. And then if you feel like, I'm driving at night and I don't need a reading eye right now, I need two good distance eyes, you can still put on a pair of glasses and minimize any nighttime issues. So the whole reason to do this lens as your premium product is having the least chance of a dysphotopsia.
Thank you, Dr. Thompson. So Dr. Cummings, artificial intelligence, can you tell us a little bit about sort of the historical background? How many patients have been, have been sort of pre-tested, tested on the device or used to make the device? And where do you see us going 10 years from now?
That's a great question. I think I like your second question a lot too. Where do you see us in 10 years? I see us in 10 years wondering how we made these decisions without the use of these devices. I think if you think about advance and the light adjustable lens, can you imagine once your cataracts have been done and you wear the device and you actually see what your visual behavior is, and then targeting the light adjustable IOL to exactly what you need? So where we are currently is I'm approaching 1,000 patients who've used the device already for IOLs. And interestingly, Ashani, is optometry is taking this up at a much faster pace than ophthalmology. And they're using this for many reasons. And one of the things they're seeing is that many of their patients are requesting a second pair of glasses because their weekday use is so different to their weekend use. And so they're tailor making devices that suit them. And this technology has also become so intelligent and so intuitive that in fact, it gives us an amazing overview of what our day-to-day work environment looks like. Now, it's not a camera, but it almost gives you an OCT of your work environment. So it's getting a very big application in ergonomics. And with so many people now working at home and companies not knowing what their work environment looks like at home, ergonomically, it's going quite a long way down the road now to help people set up home offices in a more appropriate way. So it's slow at the moment because it adds a layer of, not complexity, but it adds a layer of something in our current approaches. And our current approaches for most people I speak to are to try and be as efficient as possible. So for someone like myself who's in the vision correction space, and we would do a lot of customized treatments in the past, because our regular wavefront optimized procedure works so well, we're doing a lot more of that at the moment because it keeps people in the clinic for much shorter. So I think if this technology was used higher up the food chain and not at the level where the doctor's now going to speak to the patient, but in fact, the information was obtained from the optometrist trying to provide glasses, and then years down the line, you need cataract surgery and you can get access to that data to help design the best choice. That's what will be really valuable once it's ubiquitous.
Fantastic. And Dr. Cummings, you talked about the LMI, the Lifestyle Match Index.
So what it's doing is it's you measuring very specifically the objective data of your lifestyle. So we know now what distance you read at, what distance your computer is at, all these types of things. And that is then matched objectively against all the IOL defocus curves. So you simply, when you go through all the defocus curves, I have them all on my platform. So I can see all the trifocals we have access to and see which trifocal specifically suits this patient best, and then select that trifocal. So it's your objective singular data against the platform of all the available lens opportunities you can use.
Dr. Kazarian, we've had the ability to look at the retina for a while, but slit lamp, to tell the cell and flare, I'm feeling nervous about that. How have we overcome that in the world of telemedicine?
So that's one of the points that I was trying to bring out, is that we've used this word telemedicine as a catch basket for all kinds of different things that we do. The retinal application of telemedicine has been around for a long time, but it's mainly image transfer. And so someone will read it, someone will get back to you, here's the result, come see me, don't see me, whatever it is. Immersive telemedicine is actually bringing all the pieces that we do now in a regular exam into that immersive experience with the patient. And the thing that I don't want to trivialize is that it doesn't just happen overnight to get to be facile at doing telemedicine. And it's one of those things where the more you know about it, the more you realize there is to know. So there's training involved at all levels to get the technicians trained, to get the doctors trained to do it effectively. There's setup for the rooms, for the lighting, for the audio, there's process flow management to have that occur in efficient ways for the patient. One of the most challenging parts of the training is the slit lamp training. So to get a technician to do a very methodical, very detailed, high resolution slit lamp and exam, and then have that uploaded in a systematic way. So if I jump to 2 minutes into the slit lamp, I'll be at the endothelial part of it, whatever it is you're looking for. That takes some training. And so there's a lot of work to this. The equipment part of it is not trivial. Getting the equipment, the digital slit lamps, the high quality digital slit lamps, making sure that your devices are uploading correctly to the cloud, making sure you have file management in the cloud, making sure it's available. All this stuff goes into this transforming of analog to digital in terms of how we're doing our exams. But it's doable. We have several practices that are doing it, and once they get to it, it's interesting because both the doctors and the patients prefer it. They'd rather see patients this way. And there's nothing you miss on this. Now, of course, not everyone can have a digital, someone's going to have a retinal, a vitreal injection for AMD or something. They can't do this over Zoom, right? So there's still patients that we see. And, but for the most part, anterior segment surgeons are getting most of their in-person contact limited to the operating room. And maybe they're also doing their one-day post-op visits in person. But other than that, they're pretty much virtual. And it is possible to do that with proper training.
Beautiful. One final question. The cost benefit analysis. You see, we have about 31 countries that have registered today, right? Some of us are not as fortunate as we are in the United States. So let's talk about the ability to get the artificial intelligence device to India.
I'll start with the artificial intelligence. I think it's the easiest one. I don't know exactly where Vivia are present, but they've got quite a wide global footprint now. And what they seem to be doing is tailor making it for every single market. So it's not a big decision. It's normally not a stumbling block within the conversation. So in Ireland, for argument's sake, the cost of a multifocal IOL is €800 above a regular IOL. So when patients say, and the test costs €100 to get the report. So you don't pay for the device, you just pay for the report. And I'd say to a patient, I don't want you to do this test because I think you're spending a lot of money on the IOL. I actually think as far as the IOL goes, it's the best value for money medtech device there is. I mean, it's a fraction of the cost of a hearing aid, and you only do this once, you never do it again. But the fact that you do it once, that's why we want to get it right. And most people don't bat an eyelid. So I think for the market where it really has value, and that's trying to make the right decision in terms of a AT IOL, it's not going to be a big hiccup, but I think they are tailoring it for the market that you're in.
Excellent. Dr. Arbacer, what about iris prosthesis, human optics?
On the other hand, actually the human optics iris is extremely costly. Even in the US, it's an impediment to many patients, and there are foundations being set up within, I know Sam Maskett set up a foundation to be able to help patients to afford it. So to what extent that's really helpful. That's why I think the mortar in the right circumstances can be very helpful, where that's $100 or $200 for a mortar as opposed to thousands. So that remains a problem. And certainly, you know, as I mentioned before, people without iris often, no matter where they live, aren't the wealthiest of people by and large, unless they're traumatic, you know, so that remains a problem with artificial iris, and whether and contact lenses are not, you know, are not easily available, which is why tattooing, I think, is still, you know, practiced around the world. So certainly a pinpoint pupilloplasty, you know, is going to help an aberrated cornea patient to see well as much as something that costs thousands of dollars more. So it remains to be seen just what the uptake will be of these devices.
Beautiful. Dr. Gerd Offerth, how much does this implant cost us, and when is it going to be commercially available for all of us across the world?
Well, it's available when it's approved, and I have no earthly idea how much it will cost. I think it's much, much cheaper than having the whole setup with a human cornea and the cornea eye banking and so on. Yeah, but I cannot tell you if it costs like an IOL or if it costs like an implant. I don't really know, but I'm 100% sure it's much, much cheaper and much easier to handle. Because the infrastructure also, I mean, we have an eye bank in Heidelberg, and this is a huge amount of cost to have that and to get that approved also by the local authorities and all kinds of stuff. So I think this will be a huge game changer when this is available.
Perfect. Dr. Thompson.
As far as the light adjustable lens, I think that COVID has slowed down how it will expand into the rest of the world. But I think even more importantly, the company has wanted to have, you know, a release that has been somewhat staged and controlled, so that by the time it does go international, it can be, you know, getting to a lot of people in a short period of time. You know, these are very accurate devices, and production and those types of things, and support in all these countries, I think, is important. But I would predict that within the next 18 months, you're going to be seeing this all around the world.
18 months. I love it. So Dr. Kazarian, you know, global refractive surgery and global ophthalmology, you know how much we love that. So I'm really counting on you as well as every one of you that's here to make that possible, because we all have that responsibility. You know, I love that we have it in America and we have it in Europe, but you know, let's work together to bring it to other parts of the world where people just cannot afford it. God bless you to each one of you for doing what you do.
Make a comment on that, Ashley. You've been very modest. Ashiana's recently volunteered to lead the Global Refractive Surgery section of the Refractive Surgery Alliance. So she's going to be bringing together those people who are working around the world to bring refractive surgery to all of the world into a section of the RSA. And I want to thank you for your work with that. We're building a center now in Addis Ababa, which I'm going to be relying heavily on my friends in the Refractive Surgery Alliance to help with teaching, both through telemedicine and in person. We want to have that clinic staffed 1 week a month for the first 2 years of operation with an RSA surgeon on site. We have plenty of us to do it, but just to be there, to be present during surgery, doing surgery mentoring. With fellows will be totally trained and everything, but we want to have on-site people as well. We have a very highly functioning center in Nepal already that's being used. We bring it positioning refractive surgery as primary care for refractive error, and we intend to expand beyond that. So I want to just thank you for your leadership.
Thank you very much. I'm going to take one group shot. Okay, so everybody hands up, and audience member, we can't see you, but your hands are up too. Okay, we are going to move ahead to our next segment. And what I love about this course is that, you know, especially in the midst of COVID, what has happened is that, you know, there are so many people in every part of the world that's suffering. that have a lot going on. I am hearing day in and day out of deaths from COVID and other comorbidities. And so this time is really to realize what's important for us. Whatever faith, whatever background we come from, we are one family, okay? And so how do we bring our collective vibrations to send our peace, our love to those in need? So the next 10 minutes or so is really for us to close our eyes, okay? And how exhilarating, we've had such a high, right? We got to take that high and go within ourselves and discover who we really are in essence, that silence and the beauty of silence within us to get the answers that we really need to move ahead on our journey. So the next 10 minutes or so, I urge you to close your eyes and take this time to share your vibrations of love, peace, joy, good health to all those in need in the world and for ourselves as well. So I hand it over to my mentor, my spiritual guide, Dada J.P. Vaswani, who was noted as Saint of the Century. We have his audiovisual recording. So we are going to move forward with the Inner Sight Relaxation by Dada J.P. Vaswani.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight as far as possible. Let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now, relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest. Expand and relax. Shoulders. Lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
You know, my spiritual master taught me that the end point of education is service and sacrifice. And each one of you, each and every one of you, is a picture of that service and that sacrifice to our patients and to humanity. And with the utmost gratitude, I thank each and every one of you for doing what you do. From regeneration of the mind and body and soul to now optic nerve regeneration with Dr. Kimberly Golkowski. Dr. Kimberly Golkowski is a neuro-ophthalmologist, assistant professor at the University of Southern California Roski Eye Institute. She is principal investigator for the physiologic electrical fields, direct optic nerve regeneration, and for electric fields collaborate with CDC 42 to direct optic nerve regeneration research.
Thank you so much. Yes, good morning to everybody. I don't mean to overpromise though the potential of optic nerve regeneration. I'll definitely say that this is a topic that is of interest to many people, and we are all working together to try to overcome what will be one of, I think, the greatest challenges of ophthalmology and medicine. And I have to say that whenever I sit here and I listen to talks from anterior segment colleagues, I'm like, we're always really jealous because you have real tools that you can apply to your patients in an active manner and make an active difference. And, you know, and we have hope. And I will say that, you know, I do have real hope, although of course it comes with a lot of skepticism. I'll say that during my PhD, I watched us go from not really understanding what stem cells were to developing inducible pluripotent stem cells in a span of like 5 years. And so I think that I hope that one day we'll be able to provide something for our patients, but I do not mean to at all give you the impression that I have the answer to this. I'm just trying to work out one aspect of it. And so I should say I don't have any financial disclosures, but as all of you know, there are many, many barriers to regenerating the optic nerve. And we are working as a group, mostly together, to try to overcome these barriers. The specific barrier that our research group is focused on is directing long distance axon growth. And so this could be for neuroregenerative therapies or neuroprotective therapies. So whether it be damaged retinal ganglion cells, such as in glaucoma, providing an opportunity or signal to help them repair their damaged axon, regrow this axon out of the eye into the diencephalon, or with transplanted retinal ganglion cells, inducing them to sprout a new axon and directing their growth out of the eye into the brain. And so this is the particular challenge that we are trying to address. And I'll say that technologies that will be successful at doing this will be ones that not only drive axon growth, but also ones that are able to steer its growth to appropriate targets. And so the approach that we are taking is a bit different from others, and we're trying to develop electric field application into a technology to direct long distance axon growth. And so electric fields actually are naturally generated in our body, and the body exploits electric fields in order to direct tissue patterning during development and wound healing. And so this is an example of the skin, where this intact skin epithelium uses ionic pumps to generate an electric potential across the epithelium. And then when the epithelium is wounded, that electric potential is shorted, and this actually generates an electric field in the axis of the wound, where the positive potentials in the normal tissue and the negative potentials in the center of the wound. And skin epithelial cells are electrosensitive. They can sense this electric field, and they actually migrate within it towards the negative potential, i.e. towards the center of the wound, and in doing so actually close the wound. I should say that my mentor for this project that I started in residency is actually working on developing a contact lens that can apply an electric field to help close neurotrophic ulcers, and so corneal epithelial wounds. And so this is my little kind of bridge into the anterior segment. Here is an example of a group that showed that who measured an electric field in the developing chicken retina. And this and other experiments led them to hypothesize that this electric field actually plays a role in directing axon growth during development, and probably helps lead to the formation and development of the optic nerve head. And then, of course, there are other groups that have shown that axons of peripheral nerves grow directionally in an electric field, specifically towards the negative electrode. And so this led us to hypothesize, if we place an electrode somewhere around the eye and then another one in the diencephalon, can we generate an electric field and use this and exploit the electrosensitive properties of nerves and direct axon regeneration? And so the first pathway that we took to testing our hypothesis was to see whether or not retinal ganglion cell axons are indeed electrosensitive. And so we did this by performing tissue culture experiments. And so what you see here is a piece of retina. So I apologize to some of my posterior segment colleagues seeing chopped up retina and tissue culture, probably not too appealing. But this is rodent retina. And so we plated it in tissue culture. And if you zoomed in, you would be able to see axons growing out from the edge of the retinal explant over time. And so what I did here is I just traced the explant and then traced these axons. And then I rearranged them so that the origin originates from these crosshairs. And so these are control cultures. And you can see that the axons demonstrate indiscriminate directional growth. They just kind of grow whichever way they can. This, in contrast, is a retinal explant that was exposed to an electric field of 200 millivolts per millimeter. So the negative electrodes on this side, the positive on that side. And you can see in our rendition here that most of the axons appear to be growing towards or redirecting their growth towards the negative electrode. And so this showed us that retinal ganglion cell axons are indeed electrosensitive. Of course, we've quantified this effect and found that there's actually appears to be a threshold of 100 millivolts per millimeter above which this effect can be visualized. So here's an example of actual time-lapsed microscopy. So this is a full thickness piece of retina, negative electrode on top, and you can see that this axon here is growing out and growing towards the negative electrode. And so in our tissue culture experiments, I was able to flip the polarity of the electric field by 180 degrees. And so these pictures are taken every 15 minutes, and you can see the axon redirecting its growth towards the new negative electrode. And so we've quantified this effect and found it to be statistically significant, so occurs more often than just random turns seen in culture. And so this led us to believe that retinal ganglion cell axons are indeed electrosensitive. And so discovering this phenomenon, of course, generated more questions than it did answers. One of course, the major questions being, what is the mechanism through which retinal ganglion cells translate electric fields into directional cues? And of course, unfortunately, there really isn't enough time to go over this. And so I'm just going to kind of put that question aside, but I'm happy to speak to anybody about what our thoughts are on this topic. But I thought that to be a little bit more translational, we'd focus on the question of, will this actually work in vivo? And so of course, the question of whether this will work in vivo is complicated because there are a number of questions, such as, can we generate an electric field along the optic nerve without damaging it or surrounding structures? And then will it work? If we crush retinal ganglion cell axons, will they regenerate? And so the answers to these questions were actually much more complicated than I had ever even imagined. And so much of this work is done in conjunction, in collaboration with an electrical engineer, Dr. Gianluca Lazzi, who played a vital role in developing the Argus 2 retinal prosthesis implant. And so part of the challenge is, how do you generate an electric field? And so the thing that I didn't tell you is that most of these experiments that are performed by other people use direct current, DC current, which is dangerous because if you apply it at high voltages, it leads to charge accumulation and reactive oxygen species that damage tissues. And so we really can't apply direct current in tissue. The alternative would be alternating current, which is the same current that we have in our walls, and it's safe. But since I just showed you that retinal ganglion cell axons make U-turns when you change the direction of electric field, using alternating current probably would be ineffective. I think that the axon would just kind of oscillate in place, kind of saying like, which way should I go? I don't know what you want me to do, but it's safe. So instead, what we're doing is developing and applying asymmetric charge balance currents. And so these waveforms are charge balanced and so safe, like alternating currents, but they're asymmetric. And so hopefully possess some of the directional activity that we see with direct current. And so we've tested these charge balance currents in tissue cultures and shown that it indeed does direct retinal ganglion cell axon growth as we hypothesized. We also then proceeded to try to measure to see if we actually are generating an electric field along the optic nerve, i.e. is the optic nerve cable a conducting cable? And so we had to do these in ex vivo experiments because, as you all know, the anatomy of the orbit is very tight and doesn't really allow for precise measuring along the nerve. So we placed an electrode, wrapped one around the optic nerve right behind the globe and placed another one behind the optic chiasm. And then using a programmable stimulator, applied our waveform and literally measured within the optic nerve the current that was flowing at various distances, and this demonstrated that we indeed are able to generate an electric field within the optic nerve. And so I'm excited to show some of our preliminary unpublished work in vivo. And so here we're testing whether electric fields can direct axon regeneration after optic nerve crush. And so our experimental paradigm involves placing electrodes and crushing the nerve on day 0. And then we're letting the retinal ganglion cells degenerate for 2 weeks without any treatment. And then after that, we applied our electric field. We're doing this for 5 hours a day, and we did it for 10 days, which is very short and not enough, but I needed to see whether or not we'd have any effect and whether this was worth pursuing at all. So I chose a more reasonable time point. I don't know how many of you have basic science labs out there, but in Los Angeles, the real estate is expensive, and it includes for rodent cages as well. And then 2 days before euthanasia, we're labeling our regenerating axons with a dye. And so what you're seeing here are images of whole optic nerves. There are multiple Z image planes that are just collapsed together. The eye is on the left and the brain is towards the right, and the red arrow denotes the crush site, and the white labeling denotes regenerating axons. And so you can see that in control animals, you really get no regeneration at all. While when we apply an electric field, you can see significantly more regeneration past the crush site than in our controls. And this does appear to occur in a dose-dependent manner. And so I wanted to just emphasize that, you know, we are really excited about these results because this is one of the few examples of when application of a therapy after injury is successful at directing axon growth. Most of the approaches that other groups are taking are genetic approaches, which have shown great success in directing long distance axon growth. But the only problem with these approaches is that they're applying their therapy 2 weeks before injury because they're using viral vectors. And of course, viruses don't want to infect damaged cells. That doesn't really work. There would be no reason for them. They're not going to be able to propagate if they are infecting damaged retinal ganglion cells. So that's why, unfortunately, right now, scientists are having to apply these treatments 2 weeks before injury. And it's very hard for patients to know 2 weeks before whether they need injury. So in summary, I hope I've convinced you that electric fields may serve as a potential adjunct therapy to facilitate optic nerve regeneration, and that we're excited because this is potentially viable as a therapeutic applied after injury. We, of course, have much work that we need to do to convince ourselves and, of course, yourselves that this might work, not only in elucidating underlying mechanisms, but, of course, applying the therapy for longer periods of time to see if we can get all the way to the diencephalon. Additionally, I tried to steal this phrase from glaucoma because glaucoma does so well with it, but we're also working with electrical engineering to develop minimally invasive mechanisms to generate an electric field along the optic nerve, because although one could actually implant an electrode along the optic nerve in humans, it would be easier if we could do this by placing, for example, a contact lens and maybe like a cap with electrodes in it, and then have patients have their optic nerves stimulated while they're sleeping. And so these are experiments that we're actively working on as well. And so I really, really, of course, want to thank everybody who has helped us collect this data, my lone technician in the lab, but also I really appreciate the opportunity to share some of our promising, hopefully you agree, research. Thank you.
Thank you for having me here. I feel a little intimidated following everybody. They were awesome talks. I'm learning a lot. So in the pediatric world, we're a lot less likely to be invasive, and we're still thinking about how to diagnose stuff. So we're a little behind on interventions and coming up with treatments. So I'm going to be talking about mounted and handheld OCT in pediatric ophthalmology. So we all know that OCT tabletop has become a main test for posterior pole disease, retina, glaucoma, optic neuropathies. We have a major issue in pediatric ophthalmology, and that is it's very difficult to obtain in the younger children. So this development started at Duke with Dr. Cindy Toth, who's a pediatric retina specialist. And so she collaborated with biomedical engineering, and they brought in the handheld OCT, which eventually got commercialized, but outside of Duke. And so she's been using it for retina disease, for ROP, for pediatric retina disease. This has already been published. So she's presented her work multiple times in pediatric ophthalmology, in ROP in particular. So this is how it's done. This is out of a paper. I put the reference here. This is 2009, so that's not very recent. You can see the popcorn in peripheral ROP. You can see different stages of ROP with different stages of elevation, with correlation with histopathology. She's reported on the fact that a lot of children with ROP actually have some macular edema. Some of it leaks, some of it doesn't leak. We don't have all the FAs because you can't experiment on babies. So there's a new definition of MEOP, which is macular edema of prematurity. And she's also shown that this can, I've worked with her on this project in particular, that she can show optic atrophy and ganglion cell loss in hypoxic ischemic encephalopathy in babies. We can actually see some ischemia in the retina with a PAM-like finding, paracentral acute middle maculopathy in HIE babies. We can see some schisis in the inner nuclear layer. And she's also reported on, her and Dr. Vajzovic, they reported on the foveal maturation from prematurity to maturity and later on. So I've worked with her on correlating the retinal nerve fiber layer and the ganglion cell layer in premature babies. And we correlated it with baby IQ testing called Bailey scores at around 9 months. And actually the ganglion cell layer or the retinal nerve fiber layer do correlate with the final structural and so MRI outcome and functional outcome, baby IQs. And it predicts how much intervention these kids needed. We tried to create a normative database for this, and we correlated it with the MRI findings. So the newer technologies that they're working on, so there's the faster image acquisition, lighter machine, long arm, scan from a distance, very wide angle, scan a wider angle of the retina. We also were given a loaner mounted flex OCT, which is the same unit as the tabletop unit. The arm is not FDA approved, but we can use it in sedated, anesthetized babies. It actually gives us the same image analysis that the tabletop can give us. So we're bringing it in the operating room when we need it, but it's still a research protocol because it's the flex machine. But it gives us the exact same information. We can even do quantitative OCTA. We can do quantitative ganglion cell measurements, and it's pretty cool. So the main use of handheld OCT in my clinic is for pediatric optic neuropathies. And a lot of times when I'm seeing a child, an infant in particular with visual impairment, they're gonna come in with nystagmus. And nystagmus in particular for pediatric ophthalmologists, I'm like direct quotes from my fellows, nystagmus makes me uncomfortable, from Dr. Buckley, who's the chairman of the Eye Center. You have to make a decision with very limited information. I'm a neuro-ophthalmologist. I do not like limited information. I really like information. So the current management of nystagmus, so I took the sentence out of the BCSC and basically it says the waveform of the sensory nystagmus can be pendular or jerk or cannot be distinguished from congenital motor nystagmus. And we're figuring out more and more that the more likely scenario of an infantile nystagmus is that it's not motor, it is sensory. So assuming clear nadia, a sensory nystagmus will be caused by an optic nerve or a retina problem. Therefore, if the visual behavior is good and the optic nerve looks normal and the fovea seems present, it's okay to observe. So that's the current way we're working on this. This is the current recommendation by the Academy. If the nerve is pale or hypoplastic, you get an MRI under sedation. If the nerve looks abnormal and the vision appears decreased, you get an ERG. If the ERG is abnormal and the vision appears decreased, that's when you get an MRI. But the situation whereby you have someone with a nerve flying at 60 miles an hour that got called normal by at least 5 or 6 pediatric ophthalmologists before coming to us, and the child had a normal visual behavior for a 6-month-old or a 1-year-old, and now she's 4 years old and she can't see the 2200 line, and we're not sure if she's functional or this is congenital motor nystagmus. We don't know how much is her potential, so somebody gets an OCT and she's got no ganglion cell layer. You get an MRI and she had a glioma, and it was too late to treat it because by the time we identified it, it was 4 years too late. So this is a situation that gets me quite upset. And so this is another situation of a nerve that you could argue that it's not pale or not hypoplastic, and the fovea looks like it's supposed to be where it's supposed to be. And then you get an OCT and you see complete foveal hypoplasia. At this point, you can avoid the anesthesia to get an ERG. You can avoid the anesthesia to investigate and to get an MRI. You have an answer. You can look for Shidyaki-Gashi or look for Hermansky-Pudlak or get the genetic testing depending on how much resources you have, but you've narrowed down what you need to do without putting the child under anesthesia. This is another situation whereby this nerve was called normal, and it was actually pretty small Bruch membrane opening. And there's also foveal attenuation, so some degree of foveal hypoplasia. And this has already been reported that children with optic nerve hypoplasia can have some form of foveal hypoplasia or fovea plana. So this is someone whereby we led our workup to diagnose subto-optic dysplasia type syndrome. So now that I have handheld OCT in my clinic, and we've got the expertise to do it. We've got our own pediatric imaging center with super good technicians to acquire the images. So even if the visual behavior appears normal, I can get an OCT awake, no anesthesia. If the inner retina is abnormal, I plan an MRI. If the outer retina is abnormal, I plan an ERG. If visual behavior is abnormal and LCT is normal, I start with an ERG, and then we may, the plan is, I'm not sure about the visual behavior and there's an nystagmus, even if the OCT is normal, I would get an MRI, but up until now, I have not had this scenario. So I have not had to put a child under anesthesia without something showing on the OCT telling me what to do. So although the OCT will scan the central 6 to 8 millimeters of the retina, this gives me the central visual field. So if the visual deficit is peripheral, I will not pick it up. So that was the question that came up. But then again, if the visual deficit is peripheral, it should not cause a sensory nystagmus. It has to be a central scotoma to cause a sensory nystagmus. So we're safe that way. And a similar protocol is actually done by the DRAC lab, and you can look at her website, but she uses more the findings on the outer retina and uses more the findings that may be indicative of albinism and a lot of more genetic testing to figure out what to do. So this is what we're doing in pediatric ophthalmology. And with that, I thank you.
Maze, thank you so much for that. You know, you look so warm and fuzzy, but for those that are watching and for the faculty, you know, everyone here is just, you know, 7 stars in terms of what they're doing. It's unbelievable. And we're so honored to have you. On that same note, next up, and our finale speaker, I wish I could stand up right now and give him a standing ovation, Dr. Tamer Mahmood, who has really pioneered for us worldwide autologous retinal transplantation. Just hot off the press in the Ophthalmology Journal last month, a multi-center trial, and he is the lead author of a multi-center international trial on autologous retinal transplantation. So Dr. Mahmood, thank you so much for being with us today. It is truly, truly an honor. And I think Ophthalmology Gadgets and Gizmos really ends on a high note with you as our finale speaker. So thank you.
Thank you very much, Ashiana. This is fantastic for me. I mean, listening to all the talks we had today, I think every one of us is very focused in their own subspecialty. That I'm mostly in a retina world. So listening to all those cutting edge talks in different subspecialty makes me want to go back to residency again and understand some of the basic of that stuff. So this is fantastic. So thank you for all the work that you have been doing. It's exciting to think about all those days at Duke and all the combined procedures we did on Tuesdays. And I'm very happy to see Maze and Sid here today too. I don't have any financial disclosure related to any of the material that I would be presenting today. A few years back, when actually I was still at Duke, it was very exciting to do the first human autologous retinal transplant. And what was exciting is not closing the hole. What was very exciting is that we did it just to patch the hole so that very high myopic patients can we can prevent a recurrent retinal detachment in that high myopic patient. But what was really exciting is that initially, gradually, the vision continued to improve as the retina thickened. And then the retina started developing some outer layers, and we can see ellipsoid zone. And when we did the confocal microperimetry also, we can get some signal over the area of the transplant. So this got us excited, and we reported that initial experience. But we were trying to understand how this works and where can we go from here. Following that, multiple groups around the world in Taiwan and other places did some also pilot studies to explore the potential of the retinal transplant for macular holes and other diseases, and working on the surgical technique to make it easier, better, and understand what are the steps that we can take to move forward and improve our outcomes. So 2 years back, we also collected some of the initial cases, and we published it in Ophthalmology about some of the surgeons around the world that started doing that procedure initially, learning from that experience. And then following that, and because of the worldwide expansion of the procedure and experience, we started our global study. And we wanted to really focus on what is that initial experience? What are the outcomes that we are getting? And trying to adjust for all the confounding variables, trying to understand what can we do or change at this point to get better outcomes. So what we did in the global study is that looked at the anatomical and functional outcomes in those patients with very unusual large holes, whether primary refractory holes or macular hole retinal detachments. We had 33 surgeons from around the world, 130 eyes of 130 patients of different ethnic backgrounds. 27% were primary macular holes, 58% were refractory that had prior surgical procedures, and 15% macular hole retinal detachment. 2/3 of those had prior recurrent retinal detachment with large macular holes, and also 2/3 had prior ILM peels. And you can look at the size of those holes. This is not the typical holes that you see in clinic. The minimum linear diameter was at least 840. Those are the locations that we got the graph from. So we adjusted for all those confounding variables, mostly superiorly, but some also infranasally. 81%, we put it in the pre-retinal space. And the final tamponade in 60% was silicone oil. We also used 21% PFO and 19% gas. So 89% of those macular holes closed in those very unusual holes. So that was exciting. But also more importantly, macular hole retinal detachment that are very difficult to close, 95% closed. I'm going to focus specifically on the OCT, ellipsoid zone, and a new finding that we reported. So initially you can see the piece of the peripheral retina in the area of the hole, but gradually you see the surrounding ellipsoid zone that gradually grows under the macular hole. And this correlates with thickening of the retina and improvement of the visual function. What was very exciting is something that we described for the first time called alignment of the neurosensory layers. So when you put the graft, you see initially that vertical line between the graft and the host in the retina. And over the subsequent few weeks, that line fades away and you can see alignment, plexiform to plexiform and nuclear to nuclear. And this is corresponding when we have improvement of the visual acuity with thickening of the retina and recovery of the ellipsoid zone. So more important than vision improvement overall as a group in those very complicated cases, 43% had gained more than 3 lines, 29% more than 5 lines. And also what's really exciting for the future, there is a 12% subgroup that had vision 20/50 or better. So this gives us an idea about potentially the discussion of the role of the peripheral retina of acquiring some type of macular function. So what really, when you try to adjust for all the confounding variables, what are the basic conclusions from the study? When you close that macular hole, even if it's chronic and very large hole, you can get better visual acuity, because the first thing that comes to our mind, do we really need to care about those? We never did anything for those large holes before. And then better final vision is associated with a reconstitution of the ellipsoid zone and alignment of the neurosensory layer. And this is what we have to think about to try to achieve better functional outcomes. And how can we change our procedure to get and achieve those OCT findings? Some of the complications that we would expect for any retinal procedure, but 5 cases had retinal detachment, 5 had dislocation of the graft, but this is what we are working on. That's the worldwide initial experience. We can really overcome some of those. But this is a video of what I like to do the procedures nowadays. We make it really simple. So everything is done under PFO, so it's stable, only uni-manually if there is no retinal detachment. I get an idea of the size of the hole by the finesse loop. Few spots of diathermy because you need to oversize the graft by 25%. I use a vertical scissor to cut it under PFO. Very minimal bleeding that happens, and the laser around that area that we create a hole should be completely away from the edges. So the edges of the transplant have to be really clean because this is where you can get alignment of the neurosensory layer and better ellipsoid zone. And it's all those steps are easy for the retina surgeons nowadays. Under PFO, it's very stable. You move it step by step with the finesse loop, adjust it with overlapping one edge of the graft and one edge of the graft against the surrounding macula. So what have we changed from that initial experience and what have we learned? We know that the integration of the transplant takes between 1 week and 1 month. And therefore, this is the image, the lower image at 1 week. And you see how it completely becomes secure within that area of the hole. and then complete integration with aligning of the neurosensory layer by 1 month. And therefore, nowadays, it is much safer, and this is what I do every week, is to keep the PFO in the eye, because 100% you can close that macular hole, you provide more oxygenation to the graft when it needed initially, and you have better integration of the flap. And by this way, if we follow that very simple step, we can close 100% of those unusual macular holes, which may reflect on more functional improvement. Also, the PFO gives us a chance that we can really adjust the procedure at the 2 weeks mark when we go in to remove the PFO. So this is an example of a patient that had multiple procedures before, and you can see overriding the graft at the edge of the hole. So when I went back, when still the PFO in the eye, I can use the finesse lobe and I can slightly move the transplant. I know by OCT where are the areas that are still open, and I can adjust it in place and do fluid air exchange. And you see how nicely it is a few weeks after with the fluid air exchange and keep it in place. So this gives us a second chance, even if we are not successful or initially it slightly move out of place. There are so many hypotheses. I cannot go through all those at this point, but we can definitely discuss, and much of that has been published in the last 20 years in basic science. But I want to end with that patient that I think is very interesting to make us also understand how this works and think more. So this is one of the first patients that I did in Michigan, and she had 2 procedures 5 years prior to the transplant. And she comes at 3 months and says, oh, I see much better than anything that I have seen in the last 5 years. And you look at the vision, 2100, and I look at many of the pre-op visits, they were 2200, 2400. That's really not an improvement. So I asked her, like, can you describe to me, what do you mean by you haven't seen like this before? So she said that she had a big black spot, so a scotoma in the center of her vision in the eye with a very large macular hole. And gradually after the procedure, that became gray, and then it completely vanished after closure of the hole. So what we're thinking about here is binocular vision. She could not even open her good eye to see because she always had that black spot that bothers the good eye. So although she is testing with the same vision on ETDRS, she can function much better at different tasks for near vision, intermediate, and far vision. And when you think about it, what happens here is our optic nerve is a negative scotoma. But when we have a retinal problem, like a macular hole or some macular degeneration, we have a positive scotoma. So it is a scotoma that you can detect on a visual field, but also a scotoma that the patient express. They can see that area as a black spot. What happens here is that one of the hypotheses is that because of how the ganglion cells or the alignment of the neurosensory layer, there is some connection somehow, or something happens to that layer, increasing the receptive field, changing the positive into a negative scotoma. And this is why some of those patients, although on ETDRS, some may not show some improvement, those patients are very happy. So I don't want to, I can go for hours, but I think, let's stop here and see if we can discuss some of that stuff.
I am going to hand it over to my VR colleagues, Dr. Sheila Kerker, Dr. Aniruddha Mahendrakar, Dr. Vikram Nakate, to start us off on the retina discussion, and then open it up to all of the faculty that are here with us today to continue the discussion. So Dr. Sheila, over to you.
Hello, Dr. Mahmood. It was wonderful to listen to your talk. If you have a macular hole, how long first do you wait? Can you do the second procedure of the implant, of the graft?
Yeah, so at this stage, we don't have any timeline. If someone presents in the clinic with a small macular hole that we usually, for those, we do a vitrectomy and an ILM peel, we usually do it within a few weeks. For someone that had a macular hole before, and we are going for a transplant, usually there is no rush. I usually spend the first visit describing the procedure, describing the different options. And in my consent, I always say a repair of macular hole by any means necessary, including so and so and so. So usually I never decide that I'm gonna definitely go for a transplant. Now we're understanding more about the other procedures, and from my experience so far, the cut is usually the minimum linear diameter of 700 microns. So if the patient has enough ILM and I can close the hole and I can use some of the ILM flaps, If it is less than 700 microns, then I go for the ILM and try it initially under PFO. If it's larger, whether it's a primary macular hole or a refractory macular hole, I always go for a transplant. What we learned, to answer specifically your question, what we learned from the global study is that for cases of primary macular holes, we had similar outcomes to the refractory macular holes, but those were very large chronic
I had
macular
a question
holes. So
for
the chronicity plays a role too in how much function we can get. So I don't think we have to rush to the OR to do any of those cases. I usually plan within 2 to 3 months.
Do you think you would ever come up with something like glue or something so that it doesn't move the graft?
So great question. And this is what I was thinking about initially. When we started doing the transplant, we were very frustrated because this is new. You don't know how it's going to work. We don't understand about the function of the transplant and all this. So how can you expose a patient to a surgical invasive procedure, cut a piece of retina, move it to the hole, and then find out next day that it moved? You instantly failed. So we had to come up with something to at least anatomically be able to, securely close the hole. And this is why at this point, I really like the idea of the PFO. And I know it asks for a second procedure, but we can be 100% sure that we can close the hole and at least achieve in those patients, even if ETDRS is the same, we can get that scotoma to go away.
There is one question in our chat as well, that you suggested one edge of the graft is overlapped and the other is in line with the hole. Do you do something to fix the graft there, or what it is exactly?
No, so, if you look at one of the slides that I have with the group from Taiwan, so the group from Taiwan wanted to do it under fluid adduction. They do a gas bubble. So they thought that when you cut the graft, it bleeds a little bit. So especially if you're not using PFO, and a lot of countries and centers, the PFO is expensive. And some patients cannot have 2 procedures. So they think if you have some autologous blood also, it can help the transplant stick in place. But with those patients that are, some of them are pseudophakic or open posterior capsule, you can get condensation on the back of the lens. Your view is not going to be great. Some may have intraoperative OCT to adjust it, but the view is not going to be great. So how can you be secure that you're going to keep that transplant in place? So some have tucked it under the edges of the macular hole to make it a little bit subretinal. But we know now from the global study that it's nice to have one edge to one edge so you can have alignment of the neurosensory layers, because we're also getting a lot of function from the edge, from the original macular tissue. So what I usually like to do, because it shrinks a little bit once you cut it, one edge would be against one edge of the transplant and the other edge is overlying the retina. We know now from OCT angiography that the temporal retina moves more nasally, it's more flexible. So what I like to do is overlap the temporal edge. Nasal retina doesn't move much. So I usually overlap that and put it edge to edge on the temporal side so it can move more.
Your results were promising, and that pushes us for doing more surgeries like this. I have a question for you. Since we are cutting the peripheral retina, that's a viable retinal tissue, and placing it in the center of the macula, which already has an RP atrophy over there in most of the cases, how would you explain the viability of the tissue over there and the integration taking place over there?
Great question. So we all know, I think nowadays the exciting is not the procedure. I mean, the procedure is easy nowadays surgically for any retina surgeon. What's exciting is the biology, the biologic plasticity. So we know that retinal tissue does not regenerate, similar to optic nerve and so on. And we're trying, I was very excited about the optic nerve talk and, seeing all those things that hopefully can get those fibers to grow more and regenerate. But we know retinal tissue doesn't regenerate. But when you look at the basic science, the last 20 years, there are so many papers, for example, about peripheral Mueller cells. So peripheral Mueller cells are different from posterior Mueller cells. And in some animal models, it showed that quite some specific type of culture, peripheral Mueller cells can be prompt to stimulate and differentiate in some types of stem cells for photoreceptors. So specifically in cases of retinal detachment, when you have a peripheral retinal detachment, there is something brewing in the eye. And when you examine those areas in the periphery, some of those can already differentiate and become precursor cells from some of the photoreceptors. What we do is patients lose vision from a detachment. We never move that peripheral retina to the macula. And this is why one of our publications, even without macular hole for peripheral chronic retinal detachment, we take a piece of the peripheral retina and move it and invert it upside down to put it under the macula. Because why did we lose vision? We lost vision because of loss of outer nuclear layers. If we can provide some of those cells and the retina is already connected, then gradually the inner retina of that graft goes away and the outer retina starts connecting in 3D and we see thickening of the retina. So I think there is a lot of potential of that peripheral retina. This is one thing. The second thing is there are studies from the 70s and 80s about every one of us seems to be born with a peripheral zone of dormant cones. We don't know what that is. We don't know what happens to those cells in the periphery. If with advanced imaging, we can get soon peripheral adaptive optics, wide field adaptive optics. We're talking maybe a little bit of a science fiction, but imagine if a baby is born and you get wide field adaptive optic image of the retina, maybe the right eye at 5 o'clock has some of those cells in the periphery, and at 11 o'clock in the left eye, they have those cells. And whatever happens to you in the future, these are the cells that you're gonna tap into to replace some of those cells lost in the macula, whether it's macular degeneration or whatever that is. This is why maybe it's crazy. I'm obsessive in that way. When I go treat retinal detachment nowadays, I don't go crazy and do 360 laser. I only treat the break because I don't know what I'm killing with that laser 360.
Were there any chances of neovascularization at the graft site?
Yeah, so there is a paper that was published in JAMA Ophthalmology a few months back about OCT angiography in those grafts. And what we understand from this is gradually there is some revascularization of some areas of the graft. However, my feeling about this is that when you cut that piece of retina, you're cutting the blood supply from that neurosensory graft. Therefore, when you move it to the foveal area, it is not connected initially. So you would expect that piece of retina to die. What happens is that similar to the macular tissue, what you get initially is diffusion through the choroid. And this is also one of the advantages of using PFO. So I had some correspondence with Einar Stephenson. He's the chair in Reykjavik in Iceland. He was a Duke Fellow in the 80s, and he did great work about oxygenation. We know that the diffusion of oxygen through PFO is much more than silicone oil. And if you remember all the lung studies of the rats and so on. So that piece of retina is very ischemic initially. So when you keep the PFO in the eye, secure the macular hole to be closed, you are also providing a lot of oxygenation to that piece of retina. And this would allow it to survive until we get some revascularization. We have also seen some of the signals within the inner retina that it becomes ischemic. And maybe that initial ischemia is what produces VEGF as a source to invite the surrounding retinal blood vessels to get into the graft and provide some vascularization for more longevity of the graft.
One of your slides shows alignment of the retinal layers, perfect alignment. So was an intraoperative OCT used for it, or how do you achieve that?
So this is one of the nice things about the global study. Well, the global study also, when we analyzed all those pictures, was a masked way. So whoever was examining the OCT did not know anything about the clinical outcome. So we had a grading system for the ellipsoid zone alignment of the neurosensory layers. And we found that the graft that have nice foveal depression and alignment of those layers without eccentric holes are the ones that had better vision. So this is why now the thought process of how to adjust your graft. So maybe it's better not to put it in the subretinal area. Maybe it is good to keep the PFO and keep edge to edge. So you have a chance to avoid an eccentric hole. When you have an eccentric hole, gradually that piece can contract. You have more opening in the eccentricity, and those patients may not achieve the same level of vision. So there is something about complete closure of the hole, edge to edge, that would lead to alignment of the neurosensory layer with better outcomes. Of course, this is all based on OCT, which is an OCT finding. So this is why I changed, when we were revising the manuscript, I changed it to alignment of the neurosensory layer. Initially, I put it as linking of the neurosensory layers. Well, do we have a proof of linking? No, we don't. This is why it's just a finding on an OCT.
Regarding autologous serum and autologous platelets. Can you tell us more about that in terms of transplantation?
Initially, even before we did the autologous transplant, some have used autologous serum and so on, but this is not new. You go back to the 80s and 90s, there was a multi-center study about using thrombin and so on, and it didn't show any improvement. Actually, there was more, those patients have lost more because it seems, as a retina surgeon, you think about submacular hemorrhage in patient with macular degeneration. So all the fibrin degradation products are not good for the photoreceptors. So either you can do injections in the clinic, or if it doesn't displace, you have to go surgically and displace the blood, because your photoreceptors die and you cannot have any regeneration. Patients would lose vision. So if you physically actually bring those autologous blood and put it in the macular area, I don't think it has any value. And we can see worsening of the vision. You were using the autologous serum and all this. I think the only value is like the Taiwanese group used it to try to help the autologous transplant adhere in place if you are, for example, using air. I hope in the future we can, there are so many bright surgeons around the world, and I hope we can get to a stage where we don't have to use the expensive PFO, but we can use something that can still provide oxygenation, but provide adherence to the graft safely initially without a second procedure. We're not there yet.
Let's hand it over to Dr. Sid Gospe.
A question for Dr. Gukowski, which I think Dr. Alderi had also mentioned, which is, do you anticipate there could be a role for combining the electrical field stimulation with stem cells?
Oh, yes, absolutely. This obviously is something that we're really excited about and interested in exploring. And we've started to explore this. Of a slight note, so we're in California, and we're also really excited because our stem cell bill just passed. So it means that we're going to have more funding to investigate such things. But yes, so I've actually collaborated in part with Don Zach, who has shared some of his human embryonic stem cell line. And used his protocols to differentiate them into retinal organoids from which retinal ganglion cells can be purified. And of course, there's a lot of work being done to try to understand how much these retinal ganglion cells recapitulate natural retinal ganglion cells that we form. But we've purified them and exposed them to an electric field, and they behave similarly to endogenous retinal ganglion cells. So we're hopeful that this would be a useful therapy for that as well.
I was curious if you think, it would seem that if you had the stem cells, they would first need to grow their axons centripetally towards the optic nerve head and then posteriorly. Because optic nerve head is posterior in the eye, do you think that having that same direction of field would be helpful in driving the axons initially to the optic nerve head?
Yeah, so I think that's a really good question and difficult to answer. I obviously hope that it is, but of course our research will have to be performed to validate that. But that's why it is a major motivation for us to move forward with developing contact lens base stimulation so that we can make sure that whatever cell of interest or axon of interest is within the field that we're generating. So that's why one would have one over at the front of the eye, and then stimulation around in the back. And then of course the promise is that it seems that these fields play a role in generating the optic nerve head during development, so suggests that cells would be sensitive. And then of course also, right now we're just trying to get to the optic chiasm, but there's the optic tract as well. And the thought would be that we might, so there's a lot of dreams that are made between me and my collaborators, I should say, but the thought would be that maybe we would need to activate things in a relay manner. And so you'd have multiple relay stations, and then they would kind of activate in a relay manner, and that's how you would get and carry the axon all the way down to the diencephalon.
Yeah, if you are able to get them past the chiasm, it would be interesting to see if they hemidecussate in the proper manner, if you could label the nasal half with one color.
Absolutely. That's totally a dream of ours. I will say that in some of the genetic studies where they were able to direct growth past the chiasm in rats, so in rodents, 90% of retinal ganglion cells decussate. And so they found that many of the axons did, But the funny thing was that some of the axons after decusating grew into the other optic nerve, which we know we don't need connections between one eye and the other and skipping the brain. So that's why I didn't feel like I had time to talk about it, but that's why I wanted to emphasize that a lot of these methods are very good about driving growth, but you also really need to steer it to the correct target. And so that's going to be necessary. And then another topic I didn't talk about was, once we get them there, will they actually make a connection, right? You can only bring a horse to water. And so the thought is that neurons will make connections kind of based on use, right? And we know this, pediatric ophthalmologists are acutely aware of lack of use and deprivation and what that does to neurocircuitry. And so other groups have shown, Huberman's group, I think, has shown that activity is enough to drive synapse formation. And so luckily for us, like our activity is light based, right? And so it's good and it's easier for us to just activate these retinal ganglion cells by constantly stimulating them with light and telling them, no, there's a reason for you to stay alive, and make a connection with something downstream.
Then another question, I get this all the time in clinic, I imagine you do too. The electrical stimulation therapy offered in Germany by the Federoff group. Do you think that your work has any relevance to that? And the fields that you would be applying, would they be at all comparable to what that
so their group is doing something very different and attacking a different process. And so they're using alternating currents. So that's what I was showing, where it's not directed. And so they're not looking directly for regeneration. But I would say that, I think that their work is very interesting for different reasons. And their thought is that the mechanism through which they're restoring vision or retaining vision is by activating downstream neurons that have lost their partners, right? And so we talk about anterograde and retrograde degeneration, and neurons are like trees, right? You need a forest to have a tree. And so if your retinal ganglion cell dies, and people have shown this when they've performed high resolution MRI imaging, right? Like in the LGN, you have degeneration of neurons. So there's anterograde degeneration. And we see retrograde of occipital lobe lesions. A year or two later, you'll see topographically matching degeneration of the ganglion cell complex on OCT with having no pathology in the actual retina. So the thought is that if neurons, if they don't have their partners, we don't have partners in life, we die, right? And so the thought is that when people do these transcranial stimulations, they're kind of activating these neurons and giving them these almost like false signals that they still have their partners. And so by retaining these secondary or downstream neurons, they're hoping to help retain vision. And I actually am kind of opening a new venue of research, trying to understand whether this actually would be really useful for kind of vision processing, right? Because we think about our patients with hemianopias, right? And so if you have a right-sided hemianopia, we in in the Western world, we can't read, right? Because we can't read into blank space, right? While other groups who read vertically have no problems with right-sided hemianopias, right? So the thought is can these kind of stimulations maybe help with visual processing?
Dr. Kimberly mentioned it now. I was just wondering what the retinal specialists think about photobiomodulation for dry AMD. So people are now speaking about light therapy for dry AMD. Does anyone have experience about it? Any thoughts about it?
Yeah, definitely a huge avenue of research. And I really so at USC, we have Dr. Mark Humayun, who is a pioneer of the Argus 2 retinal prosthesis. And I really admire him, because although he's already generated such like an amazing contribution to the field of ophthalmology, he's already forward thinking and thinks his own work is like old news, you know? It's really incredible to see somebody like that. And he's like, no, we're too late. I don't want to create a prosthesis when everything is already degenerated. I want to start earlier. And so he's very interested in seeing, like looking at epigenomic changes and whatnot that occur as a result of light therapy or electrical stimulation. And so absolutely, there are lots of avenues of research that are interested in seeing this would be helpful.
She posted on the group on how many patients of nystagmus that had an OCT needed further imaging. Also, do you use May's handheld OCT regularly for ROP and HIE? Are there any specific cases where you plan for OCT?
Basically, we've been using the OCT for all ROP, HIE, any child with a neurologic disease, any child with an nystagmus or unexplained vision loss or unexplained visual behavior. So I'm being a neuro-ophthalmologist, that's pretty much my population. So almost everybody's getting an OCT. We haven't done the calculations for it yet, but what we know is that we're ordering a lot less MRIs than we used to before, because if the OCT doesn't show an inner retinal problem, we're a lot more confident that the nystagmus is not an optic neuropathy. And I've only been obtaining the MRI if the inner retina is abnormal. So I would say I'm going to get an MRI for an nystagmus maybe 5 times a year, whereas before I used to do it more. The other thing is, you know, like of the children who have an HIE, they will frequently have a homonymous vision loss that you are unable to detect by examining the baby, because you can't tell if they're not turning their head that way because of a weakness, because of a gaze palsy, or is it because of a true homonymous field loss. So the OCT will show us homonymous thinning on the macula, which will help us predict that function and will help us get them the right guidances for their visual assistance once they start school, especially because of reading.
Dr. Gala, over to you.
That was a lovely talk. And Dr. Mace, I wanted to just understand that when you said that you use the handheld OCT for all the children with HIE to prognosticate, what is it that you're kind of deciding based on the OCD finding for an HIE child?
We use the HIE in 2 settings. So the first setting was part of a study, so that was not clinical care. The minute a child is diagnosed with HIE, we actually obtained an OCT, and the study correlated the OCT with the MRI finding and the results at pre and after cooling. So from that study, the conclusions that we had is that, you know, children with HIE can actually have evidence of ischemia in the retina as well. And they can have macular edema. They can have what looks like deep retinal ischemia, very similar to the thing to PAM that you see in adults. It's not very common, but we've had a couple of cases like that. The other setting that I use it in, so I'm teamed up with the neurobehavioral neurologist at Duke, and so I will see the HIE patients because of her. And so in the older kid, like the 9-month-old, the 1-year-old, the way I use the OCT is to prognosticate what's the visual function. So I just mentioned that, for example, if there's a homonymous visual field loss that I'm unable to detect on my exam because of the patient has had an HIE, so they have weakness to that side, they may have a gaze palsy to that side, I can tell if actually there is a visual field deficit by looking for homonymous thinning on the macula, or by looking for a centroscotoma. So a lot of times the children with a neurologic disease, HIE being one of them, you have this decreased visual behavior, and we can't tell how much of it is CVI and how much is actually just a centroscotoma. And you guide the assistants to the low vision impairment, or the CDSA, the early learning disability team that works with the baby. You direct it by telling them this is what we expect they're seeing.
So it could almost help us assess the visual field in a child.
Yes,
with
by looking at the macula. Yes.
Yeah, all right. And how often do you use the OCT of the optic nerve in the pediatric population?
So if I have anybody with a suspected optic neuropathy or has an optic neuropathy, they're almost always getting an OCT in my clinic. I've been called wimpy, but I've grown to become dependent on it. And when I compare my diagnoses to those of the previous pediatric neuro-ophthalmologist who did not use OCT 10, 15 years ago, like I pick up cases whereby he called the nerve normal or some other pathology, and or like called an optic atrophy, and by the OCT I can tell, no, that was optic nerve hypoplasia, or no, that nerve was not normal. So I know that it has increased my diagnostic accuracy, but I have not looked at it in a formal way to see how much it has increased it.
But do we have enough data for what normal is for the pediatric population for a different age group? for the optic nerve, for example?
Very good question. So part of my career research has been to create normative database in kids. We started off with the Stratus, then we moved on to the Spectralis, moved on to the Flex OCT Spectralis, and some handheld automated data. The problem is when you're using the handheld, you can't really get a map because you cannot get a retinal nerve fiber layer. You cannot easily get it because when the machine is scanning, the eye's moving. So you can get one scan and then the other's this way and then the other's that way. And then you get this waves of a scan that are not easily interpretable or addable on to give you a map. So what we've done instead is, you grow an experience by looking at how thick is that ganglion cell layer, very much like Dr. Mahmood has grown an experience by looking at the outer nuclear layer and saying this is thin versus not. So we developed that experience. I don't know how to quantify it yet, but okay, I don't see a ganglion cell layer, then I know that there's a central scotoma, or I see a homonymous thinning, I know there's a homonymous thinning. So I'm using it more qualitatively than quantitatively.
We basically have gotten so dependent on this technology that we would wonder 10 years from now, where would we be without this technology? And that sort of puts the responsibility on us that we have to ensure that our diagnostic tools, our management tools are more precise and increase in that precision in the years to come.